All right, we'll go ahead and get started here. It's noon. Good afternoon, everyone, and happy Stroke Awareness Month. Thank you for joining us for the MDH Stroke Program Education Series today. We have an exciting presentation with our presenters from Centricare Health System, St. Cloud Hospital team, who will be sharing the impact of a nurse-led screening tool utilizing the Ottawa rule for identifying subarachnoid hemorrhage. Before we get started, I'll cover a few tips to navigate Teams. Today's webinar is live and recorded. As usual, your lines and videos have been muted upon entry. You can interact with us today using the Teams features. Share a reaction by clicking on the smiley face for emoji options. Feel free to ask questions along the way by typing them in the chat throughout the presentation. We will keep track of these questions and we'll try to address them at the end of the presentation or within the webinar follow-up email. If you are having any issues accessing Teams chat when it is time for Q&A after the presentation, please raise your hand and we can unmute your line. Teams also has built-in closed captioning you can turn on from the meeting controls. To use live captions, go to your meeting controls at the top of the screen and select More, and then navigate to Language and Speech, and then select Turn on or off live captions. So here's our agenda for today and learning objectives. I will start with just a couple of stroke program updates and then turn it over to the team from Centricare. We will end with some time for Q&A with our presenters. So a few stroke program updates for you. We are accepting stroke QI ward applications through REDCap. Applications are due by 4:30 p.m. Central Time on Friday, August 29th. We will put that link to the application into the chat for you if you would like access to that. And then second, the American Heart Association is now recruiting facilities for the year 2 of the Minnesota Mission Lifeline Stroke Post-Acute Care Initiative. Eligible sites include skilled nursing facilities, critical access hospitals with swing beds, and inpatient rehab facilities. And there are many benefits to joining this initiative. So if you are interested in participating or have any questions, please reach out to Sarah Donnelly at her email on the screen to discuss next steps. All right, now I am happy to turn it over to the Centricare Stroke Program team.
Good morning, everybody, or good afternoon, everybody. My name is Chandra Brower. I'm the Stroke Program Manager here at St. Cloud Hospital, and I'm joined by Shannon and Shalena as well.
So I'm Shannon Crumbita. I'm I am the nurse clinician here in the Emergency Trauma Center at St. Cloud Hospital.
And my name is Selena Bolton, and I'm a staff nurse here at the St. Cloud Hospital. And I'm super excited to be a part of this work that we're going to be presenting to you because I'm a floor nurse, so I get to work directly with it. So it's exciting that they took input from a floor nurse, and I get to be a part of this team.
All right, next slide. So our objectives for today are to describe the need for triage for subarachnoid hemorrhage patients that present outside of the traditional stroke symptoms, and then also discuss strategy for process improvement to expedite time to diagnose and time to treat subarachnoid hemorrhage patients. Next slide.
So in February, we had the opportunity to be podium presenter speakers at the International Stroke Conference in Los Angeles. And so this is Shalena, myself, and then Chandra. And on the far right is Dr. Suri. He's our program medical director for the Stroke Center. And we're actually excited. Tomorrow, we are going to the Marriott in the cities and for the Minnesota Hospital Association Award. We're being awarded the Innovation Award for our work on this subarachnoid protocol that we've implemented. So super exciting things. Next slide, please. So I'm going to just kind of start a little bit about St. Cloud Hospital. So St. Cloud Hospital is part of Centricare Systems, and we're located in central Minnesota. And the St. Cloud Hospital is like the mothership. We have 10 hospitals in the system, and we kind of lead the projects, and the sicker patients that are in our regional sites, they would be sent to our hospital for additional resources. But we have 30 clinics in our system. We have 160 outreach locations. We do have a medical school that's opening in September of this year, so we're super excited for that opportunity and the students it's going to bring as well. We have 11,600 employees, over 900 physicians and APPs, and then we also have over 900 volunteers. Next slide, please. So this is a picture of our campus. We're located on the Missouri River. St. Cloud Hospital is a nonprofit regional Catholic hospital, and it was founded in 1886. So St. Cloud Hospital has 489 beds. We have 6,500 employees at this site alone, and then we have 550 APPs and physicians. And you can see the map on there, the central Minnesota. This is all of our CentraCare locations, so it kind of gives you an idea of the area that we cover. Next slide, please. So St. Cloud Hospital has received the magnet recognition 5 times since 2004. So we're one of 43 hospitals worldwide to receive the 5th time magnet designation. So we're super excited for that. Some of the national recognitions that we've received, we were named one of the top 100 hospitals by Trubin Health and Analytics 11 times. And that's more than any other hospital in the state of Minnesota. And then for America's Best Hospital US News and World Report, we were listed as number 2 in Minnesota. Next slide, please.
So I'd like to share a little bit about our telestroke network just to kind of ground you in some of where our patients come from. We do have 20 telestroke sites throughout the state of Minnesota, ranging from nearly the South Dakota border over by Montevideo and Dawson, down to Redwood Falls, and then Monticello is our furthest site to the east, up through Aiken, Staples, and Wadena. Our telestroke providers, we have 3 stroke neurologists and interventional neurologists. They do both. And we're staffed 24/7 internally. We do not outsource any of our telestroke. And then the 30 physicians are joined by 4 stroke vascular APPs who are also credentialed at all of our telestroke sites to complete the telestrokes on those patients. Of the patients we see via telestroke, roughly 50% transfer. The other patients can be safely cared for at home. We do case reviews with each of these sites and provide a lot of resource for them as well. We are the only comprehensive stroke center in our network. There is no primary stroke center or primary stroke center plus that is associated with us. The nearest locations for primary centers would be Duluth and Brainerd. Next slide, please. So like I mentioned, we're a comprehensive stroke center through the DNB. We've been comprehensive since 2017, but we were a primary stroke center from 2011 to 2017. Our St. Cloud Hospital ED sees just over 66,000 visits each year in its 40-bed department. Annually, we admit roughly 1,000 strokes. Of those, some of them do obviously come from our telestroke sites, but many present to our ED itself. As I mentioned, we're certified through the DNB. We're also a proud recipient of the 2023 Get With the Guidelines Gold Plus, Target Stroke Honor Roll Elite Plus, Advanced Therapy, and then Target Type 2 Diabetes Honor Roll for stroke as well. From a subarachnoid perspective, just to kind of give you some background as to what our volumes look like, we do see 30 to 45 per year. Not all of them come from our own ED. Obviously, some come from our telestroke sites. In the last 5 years, our average is 10 to 15 clip procedures and 15 to 20 aneurysm coil procedures for that patient population. Next slide, please. So just to kind of review aneurysmal subarachnoid hemorrhage, this is when that vessel that's lays on top of the brain between the skull and the brain, the aneurysm has a blood vessel has an aneurysm that bursts. This creates a lot of problems, primarily interrupted blood supply. Where the blood was supposed to go, it is not getting to where it needs. The blood molecules are quite a bit bigger than the CSF molecules and therefore plug up the drainage system, and that creates problem as well because the ventricles become quite enlarged and the brain starts to swell and there's just not enough room. The additional problem with subarachnoid over ICH is that there is pressure from the subarachnoid blood sitting on top of the brain pushing down. So this can be pretty traumatic to the brain to have one of these vessels burst and have all of these things going on at the same time, and these patients are often quite sick upon arrival. Next slide, please. The incidence for these is 6 to 10 per 100,000. They do have a pretty high mortality rate. About 50% of them die even before overall, but 50% die overall. However, 15 to 30% die before they reach a hospital. The reason for that has a lot to do with social determinants of health. Where do they live? Are they living alone? Are they even not living alone, but are they alone at the time of the hemorrhage? And how quick is their access to the hospital? If obviously you're at one of our further telestroke sites, you're going to have a little bit more difficulty getting here alive than someone who presents directly from St. Cloud Hospital. These patients also are high risk for complications, including the aneurysmal rebleed, vasospasm, obviously development of hydrocephalus, delayed cerebral ischemia, etc. These patients do have quite extensive length of stay. Most commonly, these are 40 to 60-year-old men and women. However, women over the age of 55 are our highest incidence. It's really hard to determine who's going to have a subarachnoid hemorrhage, but things that impact vascular health, such as alcohol, drug abuse, smoking, hypertension, all can contribute, as well as a family history, especially those with two single immediate degrees of families who have aneurysmal development. Next slide, please. As we're talking about our case studies, we'll talk a little bit about the Hunt and the Hess and the Fisher grade scales. And I like to point out from the Hunt and Hess, this is really based on a clinical grading scale. The lower the grade, the higher your survival rate. But even if you have a patient who comes in with a grade 1 on the Hunt and Hess, this is somebody who's got normal mentation. They really don't have neurodeficits. They have some maybe nuchal rigidity, a little bit of a headache. Their survival rate is 70%. And what that means is that their death rate is 30%. What I also like to point out about this from a survival perspective is that just because they survive does not mean they go home and back to their normal living environment and their normal living situation. Because this often impacts people who are working, it could be a pretty significant impact to their family and their work as well, because they may, for at least for the immediate time, not be able to return to work, and they may not ever be able to return to work based on their deficits. The other scale you'll often see in the notes, as well as in our presentation today, is the Fisher or the modified Fisher grading scale. This is an imaging-based tool to help determine the risk of symptomatic vasospasm. And that really is based on the CT scales, and that's something that our providers utilize to help kind of guide their care moving forward. Next slide, please. We are certified through the DNV. They do accredit and certify. Some of our smaller sites, our outside sites, are DNV accredited, but they do certify us. For us, this is a triennial certification, but it's an annual survey. It's similar to what Joint Commission does for stroke certification. However, I've never been a part of those, so I can't speak to their cycles. But when the DNV comes, it is 2 days and 2 surveyors. They are so collaborative, and yes, it's a lot of work, and yes, there's a lot to do, but it is honestly a really fun couple of days of the year because we get to talk about the work that we're doing here. They visit all of our units that are impacted by stroke, from the ED to the OR to imaging to our neuro and ICU units. They'll complete patient tracers on closed charts as well as open charts based on the diagnosis. So they're looking at patients across all stroke diagnoses. They'll also make sure that they visit with staff, not just nursing staff, but also nutrition, therapy, et cetera. It's a pretty robust survey during that 2-day period. Their findings are listed as more as non-conformities and not called findings. Obviously, there's the one where they could take away our certification, but typically they are listed as a non-conformity 1 and non-conformity 2. These are issues that need to be resolved by an action plan prior to the next survey, often within the next couple of weeks. They also have a couple of other categories called observations or opportunities for improvement, and these do not require a formal action plan. These are things that, hey, as an observation, you should probably fix this before we come back. We're not seeing enough evidence to issue a nonconformity, but we don't really love the direction that this is headed. And then they'll also list things like opportunities for improvement that really don't have any bearing on the certification status, but would help improve our program and our flow overall. Next slide, please. So during our DNV survey in July of 2023, we identified a gap during patient tracers in subarachnoid care and triage. As it is with surveys, the surveyors pulled 2 of our subarachnoid charts, and they both happened to be patients who had pretty extended wait times in the ED. Their presenting symptoms were headaches, and we were trying to figure out how we could shore up that process for subarachnoid hemorrhage triage and reduce that extended wait in diagnosis and treatment time without changing our our code stroke process. So They really suggested as an observation to improve that subarachnoid hemorrhage triage. Once they left, we had a pretty robust interdisciplinary discussion with the ED, obviously, as well as imaging, to improve subarachnoid patient care by empowering nurses. We really wanted nurses in the ED to be a part of this conversation because they are so adept and so great with our code stroke process. We knew that they were our best option for triaging these patients appropriately. The guidelines had just come out in the May of 2023, so just a couple of months before, and included for the first time the Ottawa subarachnoid hemorrhage rule. And during our discussions, we kept coming back to this tool, or this rule rather, as a how we could kind of shore up and clean up our triage process. Next slide, please.
Okay, so now we're gonna kind of talk you guys through what we actually did and what we created. So I'm going to start with a case study here. We had a 50-year-old female who presented to our emergency room around 2:12 in the afternoon. She complained of having a headache, syncopal episode, or passing out, and she had some vomiting a couple times the night before. She also had been having a campfire with some of her daughters and had been out having some drinks. And at this time, she was alert, talking with staff. So we said she had a headache, put her out in the lobby, and had her wait. We were able to get her to a room at about 15:03 or 3:03 p.m., which was about 51 minutes she sat in the lobby. By the time we got her back to her room, her blood pressure was 158/91. She was a little drowsy at this time, but she was easily arousable to stimuli. The ED provider saw her and ordered a CT scan, of which we got completed at 3:55 p.m., which was 1 hour and 45 minutes after she had arrived at our ER. She, of course, as you suspected, had a positive subarachnoid hemorrhage on the CT scan. She had a Hunter and Hess of 1 and a Fisher grade of 3 on her assessment. After her diagnosis of the subarachnoid hemorrhage, her blood pressure was 140/90s. So we started her on some nicardipine, which is a medication we use in our hospital to help reduce blood pressure for blood pressure management on our stroke patients. The stroke neurologist assessed this patient around 6:18 p.m., which was more than 2 hours after she'd gotten here, and the decision was made to take her down to the operating room, where she got a lumbar drain and coil placed at 7:26 p.m. And that was a total of 4 hours since that patient had arrived. After being seen in the hospital and staying, she was able to be discharged home with some additional therapies to continue back to her normal life. So next slide, please. So looking at that, and with the recommendation from DNV, we knew we needed to do something. So we did a little research, and we noticed that 1% of all patients presenting to emergency rooms with a complaint of headache were positive for a subarachnoid hemorrhage. So again, we looked at the Ottawa subarachnoid hemorrhage rule, which had just been implemented in the American Heart and American Stroke Guidelines in 2023, the same year we got that recommendation from the DNV. What the Ottawa subarachnoid hemorrhage tool is, it was developed in 2010 by Jeffrey J. Perry and his colleagues, and they did a research across 5 different hospitals in Canada, about 1,200 participants. And their goal of the research study was really to reduce the unnecessary CT scanning of headache presentation and to decrease the number of lumbar punctures that were being done on low-risk patients. And they found they had about a 95% success rate utilizing this tool of seeing who needed those head CTs and who possibly didn't. So looking at this, that was already implemented, we just added it into a nurse-driven tool. And then you can see on the right-hand side there, it kind of breaks down what that Ottawa subarachnoid hemorrhage rule is for you. So it's anybody who presents that's greater than 15 years of age, that had a non-traumatic, so no injury, headache that reached max intensity within the first hour of starting. If they're over the age of 40, if they have neck pain or stiffness, witness loss of consciousness, onset during exertion, like lifting weights, running, a thunderclap headache, which means sudden onset of intense headache, or limited neck flexion, then they would be positive and they would need a head CT, an earlier head CT. Next slide, please. So what we did is we made an ED nurse-driven tool, because again, like Chandra had said, when you look at our ERs have gotten busier and busier throughout the nation, as you all know. Our lobby waits in our ERs have gotten longer and longer, as you all know. So who's the first person to really see these patients and do some sort of an assessment on them? It's the nurse. So we wanted to create an easy-to-use tool, because the other thing that if you want nurses to do things, you have to make it easy for them. So we made an easy nurse-to-use tool that if a patient complains with a a chief complaint of a headache, it'll do a best practice alert for this Ottawa subarachnoid hemorrhage rule. And if it's negative, the nurse will just continue with the routine triage care. And if it's positive, then they'll order an emergent order set for a stat head CT. Just a little background, nursing emergent order sets at the St. Cloud Hospital Centricare. It's a group of order sets that were implemented. They're physician made and approved that nurses in triage can start getting things started on these patients in the lobby. So like patients that have chest pain, abdominal pain, stroke fevers, and now the subarachnoid hemorrhages. Next slide, please. You can see here, this is the tool we use. So a patient arrives, they have a chief complaint of a headache. So the nurse in that top left box will click headache, and then automatically that orange BPA fires on our electronic medical record. And that's where the nurse asks those questions. When did your headache, or how did you have a trauma or an injury? And if they say no, then you ask, did your headache reach max intensity within the first hour? If they say no, and then you go to the next, if they're over the age of 40, you automatically would go down to that emergent order set and order that CT head. If they're under the age of 40, then you have to do a little bit more assessing, and you do those next 5 bullets that are up there. Do you assess, did they have any neck pain or stiffness? Was it a witness loss of consciousness, or did they pass out? Was the onset during an exertion? Did they have that thunderclap headache that just came on all of a sudden? Or do they have any limited neck flexion on exam? If any one of those are positive, then again, it automatically has you open up that emergent order set where you can order that stat head CT. And then you just facilitate getting that patient to CT as fast as you can, again, to rule out that subarachnoid hemorrhage. If they don't have those things, you just simply click just do not open the emergent order set and you continue on with your normal triage care. So with that work that we've done, we've seen, oh, next slide, please, sorry. With the work that we've done, you can see that we've improved from our patients arriving from the time they arrived to when they get their head CT, from before we implemented this nurse-driven tool to 90 minutes down to 37.5 minutes. And then how quickly our stroke providers are being able to evaluate these patients from 134 minutes down to 59.5 minutes. So the work we're doing is really helping these patients in our community. Next slide, please.
So now we're just going to cover a little bit of the data that we've been able to abstract. So we have 10 patients over the last 20 months. So our volumes are really low for this because it was specific to St. Cloud Hospital. It didn't include our affiliates or regional sites. And then it also was limited to chief complaints. So it was only for the patients that were that we abstracted with a chief complaint of headache. So you can see that we had a 58% reduction in our CT times to diagnosis. So prior to implementation, our average time was 90 minutes to obtain that CT, and post-implementation, it dropped it down to 37.5 minutes. It also resulted in a 55% reduction in our door to stroke provider time. So the pre-implementation, it was averaging about 134 minutes from door to stroke provider time. And then post-implementation, our time was 59.5 minutes. So pretty significant improvements. And so implementing these practice changes resulted in us being able to manage their blood pressure or do blood pressure management faster. We were able to get them scheduled and get them down to the OR quicker, and just really initiating the treatments faster. So for patients presenting with complaints of headaches, that we were able to capture 100% of our subarachnoid hemorrhages once we initiated this protocol. So pretty exciting work we were able to do. Look, can you go to the next slide, please? Looking at the future, we want to continue to monitor our data, and our goal is to roll it out to all of our telestrokes sites. And then we're looking to capture our CT rates for patients presenting with headaches that fall into the screening category that have a negative CT. So we want to capture all patients and ensure that we're not over ordering imaging, but we haven't been able to build that report quite yet. And then another goal is expanding the scope of practice. So right now it's only for our headache chief complaints. But we have found that some patients present with nausea and vomiting that end up coding out as a subarachnoid hemorrhage as well. Next slide, please. So I'm going to do a second case study here, and this is post-implementation. So it just shows the difference in the cares that we were able to provide. So this case study is a 52-year-old male. They presented to the ER at 4:15. You can see since he's over 40, he automatically falls in or meets the criteria to order the head CT to rule out the subarachnoid hemorrhage. So he had a sudden onset of a headache at like 9:15 that morning, and it was while he was running. So since if he wouldn't have been 40 or older, this person would have fell into the criteria because it started with exertion. So that's criteria that would have allowed our nurses to initiate the head CT. But the patient described this as the worst headache ever. He did take some Tylenol. It really wasn't, it was minimally effective. So we'll get into like the course of action. So at 16:41, so 26 minutes from arrival, we were able to complete this head CT. It was positive for a subarachnoid hemorrhage, Hunt and Hess grade 2, Fisher grade 3. This patient was roomed at 5:11 and blood pressure was like 140/79. There was no neurologic deficits with this patient. And then we consulted our stroke provider at 17:34. So that was 79 minutes after arrival. The patient did have their blood pressure managed with a nicardipine drip. You can see the blood pressure was like 146 to 150s over 70s or 82. The patient did go down to the OR for an LND and angio at 19:07. There was no coils or clipping that was needed to be done, and the patient ended up being discharged home with no neurologic deficits. So you can see that this updated process improves our patient arrival to the OR by over 90 minutes, just that process alone, and that how these changes have had a positive impact to our patient care. And it provides that earlier recognition. We're able to get that treatment started faster, and then any other additional interventions for subarachnoid hemorrhages. So this process has really enhanced our cares for our subarachnoid hemorrhage patients. Next slide, please. So that's the end of our presentation. We want to thank you guys all for taking the time to listen. Our contact information is on the slide. Sorry, I got a tickle in my throat. So you feel free to email us, reach out with questions, or we'll just take some time now to open it up and answer any questions you may have.
Fantastic, thank you. Now's the time that we can answer some questions. We've saved some time here for that. Feel free to unmute your line if you'd like to ask a question. You could also pop it in the chat.
Yeah, and I don't think you can unmute your line, but if you raise your hand, we can go in and unmute that for you.
Thanks, Jamie.
Yeah.
So I'm just going to read through some of the questions that I'm seeing in the chat, and then the three of us can kind of take kind of go back and forth and answer it. So the first question that I see is from Michelle, or no, excuse me, Haley. And her question is, have you considered implementing this in an ambulatory setting, such as a walk-in clinic? So our scope of practice for this project was to start at the St. Cloud Hospital. That was the scope. And now our goal is to roll it out to other hospitals and then roll it out to clinics or wherever we feel this work would be applicable. Sandra, do you have anything to add on that question?
I don't. And I do know that, we've had a couple of patients who have gone through walk-in that I'm aware of later that present to the ambulatory clinic and then are sent here with headache, but they're CT scanned before they arrive here. But that's certainly something that we can look towards doing. But our scope really was to start with the ED and see how well it worked and then figure out where to go from there. I see a question from Keely. What was the overall time for implementation of the results that you shared? And I hope I'm understanding this question correctly. Our survey was in July. We developed the plan and the workflow and the Epic build between then and December, with our go live and following staff education was in January. We pulled data, I believe it was through October patients, so about 8 to 10 months of patients. I do continue to monitor those. Those are all obviously minute abstraction. But that's part of the reason for the low volume. One thing I would like to mention though is the ETC nurses are so engaged with this. I was speaking with them in February or March about the new Ottawa screening tool. And one of the nurses was kind of sitting in the front. She said, I love this tool. I know that it works. One of my high school teachers came in as a subarachnoid hemorrhage patient and was able to be treated right away as a result. So having the ETC nurses be that engaged and hear that engagement from those who are has been really helpful to our success as well. Carrie, why did you go with the Ottawa tool? Because it had been specifically called out as effective screening tool in the guidelines that had just been published in May. So we thought that was a pretty strong evidence to use as a screening tool because it was just right there and easy for us to implement into our workflows.
I do want to add on to that. When we started the initial conversations about how are we going to identify these, we have a significant volume of headache patients that present to the emergency room. And so when we initiated these conversations, I was like, we are going to be head CTing half of the community. And so we needed a basis or some foundation, and having it an evidence-based protocol really is what we knew would be impactful. So we wouldn't be over ordering, and we had guidelines to follow.
All right, great. Thank you so much. There's a few more questions in the chat. So I think we picked, where do we pick up here?
I think Tess.
Yes, discussing your plans on how you're going to be involving the acute stroke readies.
So we, as it's a stroke center, the stroke nurse and I meet quarterly with our telestroke sites and go through different processes that we're doing here, things that this work being part of that. And then because we are not a system, we're a system, but telestroke is all housed separately by the organization. We've kind of talked with them about, hey, if this is something you want to implement, please reach out. We can turn it on in Epic through your sites. What we have found is a lot of our acute stroke ready hospitals tend to CT pretty early anyways, because of their limited resources, and then they come in with a headache and they tend to CT pretty aggressively and pretty quickly. We also haven't noticed as many undiagnosed subarachnoid or extended triage times that are acute stroke ready as for those patients who transfer. That said, we do have a small volume, like I said, about 30 to 35 a year for subarachnoid, but also most of them present with traditional stroke symptoms. So it's been a little bit hard to get a pulse on how effective it would be at acute stroke readies. We have talked with some of our telestroke sites who would be interested in implementing the screening tool, but nobody's made the decision from their own sites to implement this into their workflow. Kelsey's comment, this is a great question. I have not looked at the mortality rates pre and post implementation. That's a really good thing for me to do as we move forward.
And then the last question is the education involved for staff. Was it in person or classes or huddles?
I think we did all of those things. Jenna presents to our emergency department annually for some of our stroke education. So we kind of knew that they were working on it and it was like it was coming. So we kind of had a heads up that this new tool was going to be coming. And then we did talk about it on huddles. We have like update emails that come out. And then again, in our annual education for our staff, it was implemented. So every staff member gets 2 hours of stroke education annually. And that was part of the education that we implemented on there.
Sorry to interrupt. Yep. This rollout was really easy to roll out because the notification in Epic really guides your practice. And so this project was probably one of the easier for us to roll out and for staff to pick up and run with.
And we already had the emergent guidelines. We already had emergent order set implemented that our nurses are used to using. So it was easy just to add in one more, okay, subarachnoid hemorrhage. If they say yes, boom, you pop to emergent order set, you get this order, you get that patient over to CT.
The next question asks, did we turn it on in Epic? Was it something we had to have built or did they just turn it on? This was just a question that we had built in the electronic medical record. We use Epic here. And so it was literally the one question, the headache question, and did it meet maximum intensity within 1 hour? When the nurses say yes to that, then that's when it cascades additional information. So we added that question to the triage quick assessment based off of chief complaint. So they won't get that, they won't get the question, like say somebody comes in with ankle injury or chest pain, they won't get that headache question. It is driven off of the chief complaint. And it was a really easy build for our Epic team to build.
Like the fastest Epic build ever, I think. Andrew's question about how is our physician buy-in? So I'll answer that from two prongs. From a neurointerventional standpoint with Dr. Surrey, Dr. Shea, and Dr. Peterson, it was super easy. They were more than happy to clean up the triage process and be consulted sooner on in the patient's stay in the ED. From the ED provider perspective, I would say the same. I do attend the ED section meetings on a near monthly basis. And so I talk with them pretty often anyways. And then we also have monthly ETC section meetings with Shannon and Shay and several other attendants from the ED. And they really were more than happy to have this triage guide their care. It kind of saves them some steps as well. Because the nursing emergent order set was already something that everybody was used to. It was not a hard ask to have this head CT included because it's no different than the head CT that's being ordered through a code stroke. There continues to be great support from the ED for this workflow. I have, and radiology as well, because I was a little concerned maybe we'd hear from the radiology group about too many head CTs. I have heard, knock on wood, 0 complaints in the last 16 months that we've gone live. There is an ED physician in triage. I'll let Shannon and Shalina talk about that a little bit more.
Yeah, so we do staff a physician from 11 a.m. until 11 p.m. And so your early morning hours and your night hours, we don't always have a physician out there. But staff have, if there's not a physician readily in triage, they're pretty easy to get a hold of. We don't actually have the physician see them instantly. With this protocol, if they meet criteria, we expedite getting them over for a head CT. And when they get back from the head CT is when we would have them consulted and triaged by one of our physicians. So we really prioritize getting the imaging done.
But it still is a nurse that initially sees these patients in triage.
And
But the provider's there that you could go grab if you needed to for a situation. But if a patient met this criteria, you would just go ahead and order that CT and get that going right away.
And, for patients that, come in with a headache and you're say they don't meet criteria and you're kind of him and hawing which way to go, that's when we would consult, pull the physician to come maybe into our triage bay, quick see the patient, and then they would give us guidance on how to go. So if the patient didn't meet criteria, but we're like, yeah, they need a head CT, we have the ability to do that. And then these patients don't meet any code activation process. We get them over when that BPA fires that they meet criteria, and we initiate the CT. The nurse gets on the phone with CT and says, hey, we have a head CT on X, Y, and Z, and we need to prioritize getting them over there. But we don't activate a code stroke or code alert for these patients.
Our code stroke process here is built on a positive BFAST or positive VAN. And the patients that we were finding were obviously not meeting criteria for BFAST or VAN, but we didn't want to mess up that process because it works and it works really well. So we needed to figure out a way to not break the process that was working, but supplement our current triage without CTing everyone. And my first question when I was working with ED on this was, well, can we just do CT scans on people who come in with the worst headache of their lives? And they nearly laughed me out of the room because I did not realize how many patients come to the ED and say it's the worst headache of their life. So we had to be a little more specific about that as well.
And that's one thing I like about the Ottawa screening tools. It's not just was it the worst headache of your life, but did it reach maximum intensity within the first hour? You kind of rule out a decent amount of patients with just that specific piece of the questioning.
The next question says, with high volumes, do you triage to waiting room after the CT? So that patient would have to come back to the lobby once the image is done. And then we have a triage charge nurse that is monitoring results, or if we got a notification from CT that they were positive for an SAH, we have prioritized them going to the next available room or one of our stabilization rooms.
Great,
Great,
thank you.
Yeah, lots of good questions.
I appreciate the questions because as we move forward, these are great things for us to consider and to include as we're working towards this. So thank you.
Yeah, I'll give it just another minute to see if there's any final questions here before we close.
Thanks, Nikki.
And thank you guys for having us. It's fun to share the work that we're able to be doing.
Yes, thank you. I'm not seeing any more questions, but if you do, please email me or any of our presenters. We do have a QR code that will direct you to the survey for the contact hours, or you can click the survey link in the chat that Michelle just put in there. Upon completion of the evaluation, you will receive 0.75 contact hours for today's webinar. And so before we close, I would like to extend a huge thank you to the Centra Care Stroke Program for sharing your time and knowledge today. Great work, very, very exciting. And to everyone else joining today, thanks for all you do. Please stay tuned to your email for a follow-up email and next month's educational opportunity. Have a great rest of your day. Thank you.
Bye, guys.
Thank you.